We will discuss about the differential diagnosis of abdominal pain. First I will write the common diagnosis that we encounter in the ER. For example, flank pain radiating to groin. So usually you will write ureteric calculi or renal calculi. Number 1. Number 2, right iliac fossa pain, like associated with fever, vomitings. It is well known that it is appendicitis. Number 3, pain over center, that is around umbilicus. So usually the history will be outside food, having outside food. That could be colitis. And number 4, epigastric pain, like central epigastric pain, which is radiating to back. And there will be a history of alcohol consumption, recent alcohol. Maybe the patient have taken high amounts of alcohol recently. That is pancreatitis, acute pancreatitis, right? And then the 5th one, pain over right hypochondric region. Right hypochondric region. What will be there in the right hypochondric? There will be liver and gallbladder. So always think of patient may be suffering from biliary colic, cholelithiasis, cholecystitis, and as you remember, Charcot's triad, fever, pain, right hypochondric pain, and jaundice. Jaundice means patient will be having icterus. You will be seeing the eyes of the patient turning into yellow sclera. So that is ascending cholangitis, right? And then patient will be having abdominal pain on defecation, and which will be associated with small amount of bleed per rectum. Maybe the patient is having internal hemorrhoids or anal fissure or fissure in ano. And coming to the females, in female patient, for example, if there is a sudden onset of unilateral pain, for example, right iliac fossa, associated with vaginal bleed, so that could be ovarian torsion. or it could be rupture. Okay, sudden onset of unilateral pain, and mostly right iliac fossa, left iliac fossa with associated with vaginal bleed. It is ovarian torsion. And number 8, maybe patient is having young female. Patient is having abdominal pain that is similar to menstrual pain. Abdominal pain similar to menstrual pain, but this menstrual pain will be it is called intermenstrual pain, in between the menses, intermenstrual, and it is associated with vaginal bleed. Young female, abdominal pain, mostly intermenstrual pain associated with vaginal bleed. So that could be pelvic inflammatory disease. So in pelvic inflammatory disease, you can suspect endometritis. You can write in differential diagnosis, in provisional diagnosis of endometritis, or if the patient is having signs of sepsis, it could be tubo-ovarian abscess. So we see rarely in our ER department. And then so a pregnant female having abdominal pain with PV bleed, maybe she is having threatened abortion. And now the two important diagnoses which you should never miss in the ER. One is ectopic pregnancy. Number 1 is ectopic pregnancy. So how will the patient will be presenting? Patient will be having no menses, presenting with abdominal pain, and LMP will be like not LMP, like patient will be pregnant 6 to 8 weeks. 6 to 8 weeks pregnant. So there will be unilateral pelvic pain. See, why I am telling 6 to 8 weeks is like it takes 6 weeks to get this egg fertilized and forming into embryo, and when this embryo attaches to the fallopian tube, that will get ruptured, and these contents will be going into the abdominal cavity, causing severe pain. So ectopic pregnancy you should never miss. And last one is ischemic bowel or perforation. See, always remember, suppose patient comes to you with abdominal pain, you have treated that patient with number of painkillers, but pain is not subsiding. So we call this as pain out of proportion. Patient will be having severe pain. Sometimes they will be presenting with shock. So what you have to do immediately? You have to take ABG, which will show high lactate. So immediately you have to refer to surgeon. Maybe the patient is having ischemic, sorry, maybe the patient is having sometimes gangrenous bowel secondary to ischemia turning into gangrenous bowel, we don't know, right? So what will be the investigations? There will be bedside investigation, will be ultrasound and ABG if you are suspecting perforation, and then CT abdomen. So you should never send a patient to CT abdomen if the patient is unstable, otherwise patient will collapse and cardiac arrest may happen in the CT department itself. And if the patient is stable enough, you can do X-ray erect abdomen. X-ray erect abdomen will show the various fluid levels. You will see the intestine, and you can see the fluid levels, and if perforation is there, you can see air under the diaphragm. And the most important and most common diagnosis in ER is DKA, diabetic ketoacidosis. So young patient, not only young, any patient presenting with abdominal pain and vomitings, always think of DKA. So this is very important. Thank you.